evening, everybody. My name is Cindy Wu. I'm the lead Next Generation editor for the ASJ. I want to welcome all of you to our 6th live journal club, which is held the first Tuesday of every month at 8 p.m. I want to thank the ASJ staff, in particular Phaedra Kress, who work very hard behind the scenes to organize this event every month, and Kylie is also on the call with us tonight. So I would like to introduce the author of this article, Dr. Mark Clemens, who is an associate professor of plastic surgery at MD Anderson Cancer Center, University of Texas in Houston. He completed plastic surgery training at Georgetown University, research fellowships at the U.S. National Institutes of Health and Harvard Children's Hospital, as well as a microsurgery fellowship at MD Anderson Cancer Center. Dr. Clemens' research interests include breast implant-associated ALCL, as well as robotic-assisted microvascular and prosthetic reconstructive surgery of the breast. Dr. Clemens has lectured in 27 countries and written more than 90 peer-reviewed articles and 50 book chapters. He is the breast section editor and on the editorial board for the Aesthetic Surgery Journal, and is treasurer and a board officer for the Aesthetic Surgery Educational Research Foundation. He is an author for the National Comprehensive Cancer Center Network Guidelines on Lymphoma. He was a member of the surgical team that performed the world's first skull and scalp transplant. So tonight, we have the pleasure of having Dr. Mark Clemens on this call tonight, who will give an overview of the article. And then afterwards, we're going to open it up to you for questions. So just some logistics. For those of you who are joining us via video, please type your question into the chat box at the bottom center of the screen, and it will go to either Phaedra, myself, or the whole group. You can designate who the question is going to. If you are joining us on audio only, please email your questions to Phaedra, which is P-H-A-E-D-R-A, @surgery.org. And for those who cannot join us tonight, this journal club will be recorded and available on the ASJ website. Throughout this Zoom meeting, we will be curating questions, so we may be looking down at our phones as the session continues, so please excuse us. We're just trying to sort through all your questions, and we will call on the question asker, and you'll have the opportunity to ask your question directly.
Thank you so much, Cindy. I really appreciate that introduction, as well as Phaedra and to Dr. Nahai for the invitation to be able to speak to the Journal Club tonight. I think it's important just to kind of lay out the logistics, if you weren't on previous calls, that as a journal club, we go into it assuming that everybody has read the article. And so I don't want to necessarily rehash or tell you everything in the article. I want to spend just about 5 minutes, maybe 5-10 minutes, talking about what prompted the reason for this article, maybe some behind the scenes things about what we were thinking as we were writing it, and then what was the take-home message that really changed our practice based on the results of this. So kind of, the next level of what you would get from this article beyond just the numbers and the raw data. I do want to recognize some of my co-authors that were involved with this. So Dr. Elizabeth Craig is in private practice here in Houston. She was a fellow during the writing of this manuscript. Some of the other full professors at MD Anderson, Charles Butler, who's my chair, Patrick Garvey, Jesse Selber, both full professors, and Stephen Kronowitz, who obviously is known for breast reconstruction and now is in private practice here in Houston, Texas. While there's a number of different manuscripts out there on ADMs, we didn't want to redo just another manuscript on that subject. What we wanted to take was our unique experience with radiotherapy and to look at it from an oncologic perspective, as well as from a very rigorous academic perspective. What was ADMs using with radiotherapy? So if you can advance the slide. I do have the following disclosures. I was an investigator for the Athena trial. I am an investigator for the Motiva trial, and I was a former consultant for Allergan. I'm no longer a consultant for any company at this point. Advance the slide. So as an introduction, we know the benefits of ADMs. I think that particularly within the United States, I saw some Canadians that are watching, but I can say in the United States, ADMs have become ubiquitous within our breast reconstruction practices. Most of the previous papers written on this are to secure the pocket, improve breast shape, reinforce the inframammary fold, really act as an internal bra on the inside of the breast pocket. It also has allowed for higher intraoperative fill volumes in prospective studies. But I think one recurring theme that we've seen over and over again is the high complication rate. So high seroma, high infection, high explantation. And that's definitely true in the MD Anderson experience. We device does across the board increase those complication rates, and they're even higher with radiotherapy. Advance the slide. So our question that we were asking is, what is the effects of radiation therapy? And I have to say my general thought was going into this that when we look at use of a tissue expander and radiation, or the Kronowitz delayed immediate type of reconstruction, which is very common at MD Anderson, what we see is that that has a high complication rate by itself, and that it's very dependent upon patient selection. And so you do not want to do a tissue expander immediate reconstruction knowing that there's radiation therapy in a high-risk individual. And by that I mean morbid obesity, diabetics, smokers. And I really thought that ADM would be considered such a big hit in these patients that it as well should be a contraindication when knowing that you need radiation therapy. But that was the hypothesis that we were asking. Advance the slide. And so I know that you've read the article and you know that there was 4 cohorts, but I think it's important to just visually see these. We're looking at no ADM, we're looking at with ADM but no radiotherapy, and then both of those same cohorts with radiotherapy. Now, I've said there's a ton of manuscripts out there looking at ADM versus total muscle coverage. There's also manuscripts, a few, probably half a dozen, looking at the effects of radiotherapy, but in almost none of these manuscripts do you have all 4 cohorts. The ability to look at every single one, ADM with RT versus ADM alone, or total muscle coverage versus radiotherapy with total muscle coverage. In fact, the only one that I could find was by Dr. Scott Spear, who was my mentor, in about 2009. It was a very small cohort, less than 100 patients. Advanced slide. Now, as you can actually see, it's much larger in this one. This is 1,370 breasts and 957 patients. So just by that, radiotherapy or not, it's one of the largest series ever published on ADM use. You can see that the vast majority of patients are non-radiated, 85%, with radiated beating 15%. Graphic has changed. So this is a historical cohort of that ended in about 2015. But as of today, we're seeing more and more radiated patients. The indications for radiation are expanding. And so our radiated patients are up to about 25 to 30%. So I think of radiation therapy, if we were to look at a snapshot of today. And I can see the average follow-up is 210 days. Advance the slide. Let's go into some of the other findings. So this was the real meat of the manuscript, and you've probably already seen this figure before, but it looks at the main drivers of complication. And we see that the most common drivers that we know in ADM use show up here from previous manuscripts, specifically infection and mastectomy skin flap necrosis. And I always take that we would have done with total muscle coverage. We're getting more fill on the table, but that's going to stress our skin flaps more. That definitely was part of my own learning curve when I first started using ADMs. I had more skin flap necrosis. As I backed off on those fills, then I was able to decrease that risk within my own patient population. Now, if we look at that infection and necrosis as being drivers for explantation, what was absolutely a huge find in this manuscript was that bottom row, explantation, or what we call a complete failure of the reconstruction. We know that the addition of ADM over total muscle coverage increases complication, and notice it about doubles from 6% to 10%. Anytime we add that foreign body, it's going to increase the complication rate. However, what was really surprising by this manuscript is what happens when you radiate it. When you radiate a total muscle coverage, that explantation rate goes up fourfold to 20.4% in our experience. Yet what happens if you have ADM in that pocket? Now at this point, it barely gets a blip, 9.5 to 11.4. The effects of the radiotherapy are incredibly muted, in essence, not having the deleterious effect of the radiotherapy. So the use of ADM is definitely an independent risk factor for an infection. However, there is this longer-term benefit that we are seeing. Advance the slide. And you can just see some of the risk factors for explantation. We know that higher preoperative bra volume does it, higher initial fill volume does it, BMI, nipple-sparing mastectomies, all the things that you know that increase complications. Yet, surprisingly, with the addition of radiotherapy, the use of ADM was actually muted. So go to the next slide. Now, this was a critical aspect for me visually to see for the manuscript, and it's showing where the complications are occurring if they're going to occur. Now notice ADM, huge spikes in the beginning. In those first couple of weeks, before the ADM is incorporated, we are seeing a complication profile like a foreign body. It has not incorporated, it's prone to seroma. Those seromas can become infections. And so you have all those perioperative complications, which are higher than the total muscle coverage. However, notice what happens at about 5 to 6 weeks. You get your device incorporation of the ADM, and then after that, they're pretty much negligible. The early peri-op complications of infection and seroma drop off. But in the delayed complications, we would usually see explantation on average in this paper somewhere between 80 and 110 days. That's right during the radiation phase. We see that because total muscle coverage is similar to ADM, those drivers of complications before are no longer problems. And now we can actually see that the ADM has imparted a benefit to the reconstruction. In essence, it's made it more durable. It acts as a block for the radiotherapy. We know that radiation-induced capsular contracture is very much a fibroblast-mediated phenomenon. And just as we've seen that ADM has been helpful in capsular contracture, I think it's truly acting as a bio-block or just preventing contracture and really helping to add an extra protective layer over that tissue expander. Go to the next slide. So in summary, ADM use obviously increases overall complications, infection, and seroma. However, it has a marked decrease in expander failures in radiation therapy. And so in these situations, we really feel that there is a clear indication for ADM and a benefit for it. Advance the slide. So the decision to use ADM for expander-based reconstruction really is very patient selective. You need to take into account comorbidities and use it judiciously. it will increase your complication rates, particularly for infections and seromas. And when you're doing your patient selection, you have to realize what are the biggest drivers for those complications. Radiotherapy in prospective level 1, level 2 data is the single most driver of complications in tissue expander breast reconstruction. It is the single biggest driver in multivariate analysis for both overall complications and infection. ADM, also a driver, older age, higher bra volume, and smoking. But while radiation therapy may be synergistic with these other factors, it is actually protective with ADM. And so, therefore, as we look towards the future, when we're using these incredibly expensive devices, we need to come up with some ways to justify that cost if we are going to use them in our patients. If they just increase complications, they're not worth the thousands of dollars that they cost. If there is a tangible benefit, a market benefit to that patient, in this instance, an entire salvage of the reconstruction, then you can make an argument that it's a clear indication. So with that, this was a big practice changer. We actually really seek out radiated patients for the use of ADM. And I would say, just to update this paper, we have seen shifts in the overall practice. We see more bilateral cases. We see more nipple-sparing mastectomies. We see more pre-pectoral breast reconstruction. In fact, in my practice, I'm approximately 100% pre-pectoral breast reconstruction for the last 2 years. That has changed. For this paper, it was total muscle coverage, and we didn't want to obscure the data and throw in another confounder. But I still think that there is market benefit, particularly in pre-pectoral. I see that it's very resilient to radiotherapy. So with that, I want to open it up for discussions. I've probably taken a little bit too long. But Cindy, do you have any questions?
Yes, we actually, thank you for that lovely summary of the article. We actually have a question from Dr. Tuma. Dr. Tuma, would you like to ask your question?
Sure, sorry, I unmuted myself. You kind of answered it, Mark, at the end in regards to the pre-pectoral versus submuscular and ADM. I think your points are very, very valid. I think the ADM is more resilient to radiotherapy, and I certainly think that pre-pectoral placement with ADM is even more resilient because you just don't get that fibrosis of the pec muscle, which causes much of the complication associated with radiotherapy and tissue expander reconstruction.
Yeah, I couldn't agree more. And that's been an enormous epiphany. I really consider myself a late adopter of pre-pectoral breast reconstruction. I really, it was hard for me to go over it. I had performed some just a mastectomy skin flap closure over tissue expanders. We had tried to get it to work years ago, and it was such an abysmal failure that I really was skeptical about pre-pectoral. I became a heavy use for it about 2 years ago, and I've been very happy, and I've really seen an enormous benefit in radiated patients. It's amazing the effect that the radiation therapy has on the contracture of that muscle. I think when we see so many breast reconstructions really elevate up, ride up, it gets really tight inferior pull. It's not so much the skin that's contracting on there as it is the muscle contracting and pulling the entire reconstruction up with it. Mm-hmm. So a combination of ADM for support of that pocket, leaving the muscle down on the chest wall, is really made an enormous benefit and opened up more patients to a prosthetic reconstruction in exchange that I would have traditionally required an autologous reconstruction to. In fact, when people think of MD Anderson, they usually think of a mantra of radiation therapy equals autologous reconstruction. I know Stephen Kronowitz beat that drum for a decade and a half. But the reality is, if we're looking at our numbers just in the past couple of years, approximately 1 out of every 3 radiated patients at MD Anderson is reconstructed with a breast implant. Now, that's nearly sacrilegious. That really breaks a lot of dogma. We have very heavy radiation protocols, but more and more and more, we're doing prosthetic reconstructions. I also see a great benefit is fat grafting. The ability to fat graft these prepectoral skin envelopes really opens up a lot more patients to a prosthetic reconstruction.
Yeah, I mean, I couldn't agree more. I think, you know, traditionally we were so nervous about using implant-based reconstruction in the radiated patient, and this flies right in the face of that, but it holds up so much better with the ADM. And in regards to the cost and the justification of the cost, I mean, the operation now has become almost simplistic, and time in the operating room is so minimized with the technique of prepectoral. Plus, it holds up so well against the radiotherapy. And with the advent of more bilateral reconstructions, it's just become a much more straightforward operation, in my hands at least. I couldn't agree, Mark, more with your observations. And I think, you know, this is going to be the wave of the future for most reconstructive surgeons.
Yeah, let me ask you something. One thing that we've been seeing is we'll place the tissue expander up front, and then I say to them, we'll see how you do with radiotherapy and whether you become an autologous candidate just because the skin quality is poor and you're not tolerating it, or you'll go to a prosthetic reconstruction. I do my exchange after radiotherapy 6 months from radiotherapy, and I think that that gives me time to see how that pocket looks and gives it enough healing time. I think longer than that isn't absolutely necessary. One thing that I've been doing in my practice is, and this is for the in-betweeners, the people that are just right on the borderline at about 2 to 3 months, I will take them to the operating room at 3 months, knowing that I'm going to exchange them at 6 and just fat graft it like crazy. In fact, I did one this morning. And just adding a ton of fat graft, I gave about 200 cc's to one breast, really thickened up those skin flaps. And the idea is coming back at 6 months and then doing a prosthetic reconstruction. And I can tell you the skin flaps look fantastic, and that enables me to, you know, as much as I like doing microsurgery, it saves a young patient with, you know, no donor sites, and she was 34 this morning. It was a great option for her.
Mm-hmm. Mark or Gard, I have a question. Do you ever do prepectoral direct to implant as opposed to prepectoral expander reconstruction?
I do, and I really like that procedure. I'm doing more and more direct to implant. I like the way that you said it. I don't call it one stage because it rarely is. It usually gets some kind of touch up. But I do like it. I would say definitely for my A cup, B cup breasts, I'm going to always go direct to implant. C cup, I'm going to really evaluate those skin flaps on the table. And I've been very unhappy with anything over a C cup. One of my partners today, Don Bowman, he just did a direct to implant with a 700 cc implant, and I was watching him, and I'd say, you know, that it's a roll of the dice anytime you do that.
That's a little risky.
You know, I don't advocate. Yeah, it's pretty risky, and so those patients, I think you got to two-stage them or do an autologous reconstruction.
And is your method to sew in the alloderm or ADM first and then put the implant in, or is it a wrapping and dropping, which is off-label, but people do it?
So I love the wrap and drop. It's like we just said, it's so fast. I can make that on the back table, and then I can sew it into the patient in, 5 minutes. But it really depends on what the approach is. So for a midline skin-sparing mastectomy, I can just wrap and drop in there. For an IMF incision, I actually find it difficult to wrap and drop and get good tacking down of the superior aspect of that construct. I've tried it in a deflated fashion. I've tried it in different ways, and I just can't get it in. So instead, I will actually sew in the ADM in the shape of the pocket that I want, and then introduce the tissue expander through the IMF incision underneath the ADM, and then sew the ADM down to the chest wall, closing up that pocket. It's just I get better results, better shape through an IMF incision by delivering it that way versus the wrap for a mid-breast incision.
Mark, when you do the wrap, you're just talking about a tissue expander, not direct. You don't wrap the implant, do you?
That's correct. I haven't found a good way to wrap the implant and get it to stay on well. But with the tissue expander, I wrap it.
Yeah, I wrap pretty much always tissue expanders, and I agree that superior stitch is difficult. But if you parachute it, you can put it where you want to. And it's a little challenging at first, but after doing it a couple times, it ends up being just fine. And I do agree, the fat grafting, I prefer, much like Peter in New York, I much prefer to exchange before radiation and then fat graft after radiation. I think that ends up being better. But, Gino Regali has a lot of good data about fat grafting and stem cells and rejuvenation of tissue in regards to radiated tissue. So doing it, in anticipation is going to make it, I think, more robust. I also think the last thing happens to be how thick your mastectomy flaps are from your breast surgeons. If you have very thin flaps, which I know you guys have down there, it's more challenging. If you have a thicker flap to begin with, it's even more robust. So that's just a couple little added caveats.
You raised Peter Cordero's experience, and I've talked to him about it because he still does have a large experience of radiating the tissue expander, but most of his manuscripts really advocate for radiating the implant. He said while he prefers to radiate the implant, a lot of it is dependent upon the chemotherapy that they're receiving. So if it's neoadjuvant chemotherapy, you only have 4 to 5 weeks until postoperative radiotherapy. He says that he has given up trying to exchange at 1 or 2 weeks. You can imagine 1 week after a mastectomy or 2 weeks after a mastectomy trying to exchange that. He said he's given that up. However, if it's adjuvant chemotherapy, so if he's got 3 months or 6 months of chemotherapy before that radiotherapy, then he will exchange prior to the radiotherapy. And so I think that that's an interesting perspective, is that I don't necessarily see it as MD Anderson doing one and Memorial Sloan Kettering doing another. It's very much type of chemotherapy that's given to us. And if you've got 6 months to manage and perform another surgery, you have a lot more options.
Totally.
And that's a main driver for that.
So we have time for one last question, and we have one more from Dr. Wright Jones. Dr. Jones, would you like to ask your question, please?
Hi, everyone. Mark, first of all, I want to commend you on a great study. I was just curious. I noticed about 25% of the surgeons use SurgiMend and about 75% use Alloderm. I was wondering if you saw any trends in difference in complications between the two, or if you even looked at that.
Yeah, so not within this study, but we did a prospective randomized controlled trial of Alloderm versus SurgiMend. And I think that this study caught up a lot of those patients because we included all of the patients they were using at the same time as doing the study. We did that prospective study, which actually has not been published yet. So I can let you know how that went. We didn't see a higher failure rate, explantation, infection. All of those were similar between the two groups, except for seroma. Seroma was double in the SurgiMend group. Exact same surgeons randomizing between the two, and we ended up with a double seroma rate with the SurgiMend. Because of that, SurgiMend fell more out of favor among our surgeons. I'd say we were up to about a third of surgeons using it during that time period, and it's dropped down to about 1. Also, too, there was a lot of pressure from the FDA about xenografts, saying that they weren't they didn't have a clear indication for a device on. They didn't have a device-on-device exemption. So the idea of using it as a pectoralis extension. TEI Biosciences received a letter from the FDA saying to cease and desist from their advertising campaigns. Allergan received one for Stratus, as well as Seri. Really, all of the xenografts got that letter. And so I think we've drifted away from using xenografts within the breast. I think if you looked at a snapshot of the numbers how they are today, it would probably be closer to about 95% to 5% for SurgiMend to Alloderm. I don't advocate for Alloderm, though, over the other human grafts. I think that they act relatively equally. We've seen very similar rates with Dermacell, as well as, just about any of the human allografts we've seen work similar. But I think that the xenografts, maybe why we saw the higher seroma rate, is because I think that in my hands, they seem to be a little bit slower to incorporate. If I was going back and doing the exchange faster than expected, more of the device would not be incorporated. If I waited long enough, it would all be incorporated eventually. But I think it was a bit slower, and because of that, they're a little bit more prone to seromas and maybe leaving the drain a little bit longer. Do you have an experience with
not a lot, but I'm pretty much an Alloderm guy.
Right. So I am too.
Well, we want to be respectful of everyone's time. I want to thank everybody who tuned in tonight and joined in for our Zoom Journal Club. This will be every Tuesday, first Tuesday of every month at 8 p.m. And if there are no more questions, thank you all for your time and have a great evening.